Good afternoon, everyone, and thank you for coming for the launch. So I'll focus my talk mainly on the behavioral aspects of headaches and also the non-drug treatments of a headache. So I'll begin by reading this, Tale of Two Migraines. So those of us here who are familiar with Charles Dickens' works, you may may realize the similarity. It was the best of times, it was the worst of times. It was the age of serotonin and the 5-HT agonist. It was the age of analgesic rebound and medication overabuse. Certainly in the guidelines, there's quite a large element on the medication overuse headache, and also it was the epoch of non-pharmacology. Therein lies the importance of non-drug interventions when it comes to management of chronic headaches. Previously, when Charles was working in SGH, certainly we have quite a lot of collaboration going on, where all these patients with chronic headaches very often they not only benefit from pharmacotherapy, but they also benefit from the non-drug interventions. It was a season of disability, so certainly you can envisage that a lot of patients with chronic headaches, they do find the condition rather disabling. It was a season to function heroically. So very often, we also encourage them to. Some patients they actually try to cram in as many activities as possible, and then after that, they realize that because of the hyperarousal, after that it's followed by a very severe headache. So when you talk about stress management, certainly we need to tackle that aspect as well. It was the winter of comorbid depression, and like what Charles has emphasized, certainly for a lot of patients with chronic headaches, they also have psychiatric comorbidity, be it anxiety, depression, and also in my clinical practice, I realized that a lot of them do have some underlying personality disorder. So certainly, early on, the previous slide kind of emphasized the behavioral issues involved in the management of chronic headaches, analgesic overuse, non-compliance issues, disability, and certainly psychiatric comorbidity. So very often for these patients with chronic headaches, so when taking the history, I will emphasize on the A, B, and C. A is referring to the antecedents. What happens, what brings on the headache? Be it external risk factors like triggers, what are the conditions that will bring on the headache? Like let down from stress, like when they are trying to do their best for a particular stressful event. After that, then they'll start to have a headache. And their own thoughts, the cognitions, feelings, and behavior when they have the headache. And a B is a behavior, actions taken as the headache become worse. And some patients actually have getting, as I emphasized earlier on, getting as much done in as short a time as possible before the headache actually really hits. Because they kind of feel that the headache will be coming soon, and therefore they try to cram in as much activities as possible, and that kind of makes the headache worse. And also we need to look at how the family members react, sees the consequences of the headaches. We need to look at the impact of the headache, the response of the family, whether in any way all these responses kind of reinforce the headaches. So again, in terms of the history, very often we need to look at the headache diagnosis, the frequency and severity, the analgesic or use, overuse, and abuse. And I'll be focusing more on the behavioral and stress-related risk factors, and also the comorbid psychiatric disorders. Okay, what I find very useful is to get patients to keep a headache diary, and we get them to record all these things down: the headache intensity, the duration of the headache, the possible triggering or aggravating events, and also when they have the headache, what kind of medicine they use, the dosage, and the frequency of the usage of the medicine. Very often, once you have get patients to start documenting their headaches in a diary, that kind of save a lot of treatment time by focusing the discussion. And also you need to realize that the memory for pain is prone to distortion. So if patients don't record them down, after a while they can't really give a lot of details regarding the episodes of the headaches. So certainly these are all in the guidelines about medications overuse headaches. And in terms of the behavioral and stress-related risk factors, certainly we will focus on the stress that can bring on the headaches, and also for major life events. Typically, these are, say a death in the family or hospitalization or some other stressful events that were going on in their life. So stress is a non-specific physiological and psychological response to events perceived as a threat to one's sense of well-being. It is a state of tension caused by emotional, mental, physical, or social pressure, and very often is a common experience in meeting the demands of life. So stress becomes harmful when it's rather excessive. So we're not sure who's facing more stress. Is it the chair or the pet below? So again, once there's something stressful going on, if we have all this adrenaline, noradrenaline that will surge in our bloodstream. So and all this will help us to combat stresses better, and if we succeed, that will help us overcome our problems. If somehow, because of the stressful events, we're not very successful in coping with them, and then we have a long-term side effects of depression, anxiety. And very often, the way we cope with the stressful events is very much influenced by environmental factors, and also the way we appraise our judgment judgment, the way we appraise the stressful event. And very often that's linked to genetics, linked to our upbringing, our pre-morbid personality. So these are the issues that we will try to analyze and come out with the formulation together with the patient. So these are some of the common signs of stress. When people are under lots of stress, they will eat poorly, they tend to drink more alcohol or consume more coffee, smoke more cigarettes. And just to talk about the symptoms of a major depression, it's useful to remember these mnemonic prescribed energy capsules that help us to elicit all the features of a major depression. Typically, they have sleep disturbances, they have loss of interest, feeling guilty, loss of energy, poor concentration, loss of appetite, or loss of weight. And very often they have psychomotor retardation or agitation, and very often they also have all these negative thoughts, suicidal behaviors. These are some of the symptoms of anxiety. They will present with anxious mood, again, sleep problems, psychomotor restlessness. Very often they have muscle tension in their body, complaint of fatigue, loss of energy, and also they have this tendency to keep on worrying, poor concentration, and also irritability. These are all the symptoms of anxiety. So these are the common kind of anxiety disorders that we encounter in our clinical practice. Typically, it's the first two, generalized anxiety disorder, where they have this constant apprehension, keep on worrying, very, very anxious preoccupations. Then panic disorder is more like severe attacks of anxiety, where they feel that they can't breathe, have palpitations, and feel that as if they're going to die and going to collapse. So very often, a lot of our headache patients also have insomnia, and these are some of the psychological causes of chronic insomnia, depression, anxiety, or even someone who's going through something rather stressful, life stressors, and having a chronic headache certainly is very, very stressful for many patients. And locally, I do realize that a lot of our patients have this phenomena of bedtime worrying. So very often in the daytime, they may not report feeling anxious or anything like that. But comes evening, comes bedtime, the minute their head hits the pillow, their mind will start to wander. They'll think about the events that happened in the daytime. For instance, I have this patient who told me, he will start to wonder, I bump into my boss along the corridor. Somehow he didn't reply my greeting. Will I lose my job? That kind of thing, yeah. After that, he will start to think about what's going to happen the next day, all the minutes that he has to take, all the meetings he has to attend, all the work that has to be finished, and all that. Then he start to worry about the tsunami, worry about earthquakes, or worry about Third World War, nuclear warfare, so on and so forth. So you can imagine, when you're lying in bed, your mind keeps wandering, and you keep on thinking about all these things. You feel so anxious and worried that there's no way you can fall asleep. So certainly, we need to tackle this problem as well, because they will tell you, if they can't sleep well at night, the next day the headaches become worse. So the way out for them to tackle this problem of bedtime worrying is actually to teach them time management or stress management skills, where get them to say schedule some time in the daytime for worrying. This is what we call the worry hour. It means in the late afternoon, early part of the maybe in the late afternoon, they can actually put aside some time, be it 15 minutes or half an hour, where they actually sit down and get out a piece of paper and then start to to list down all their worries and concerns. They can ruminate, they can think about what has gone wrong today, what's going to happen tomorrow, so on and so forth. So the minute they start doing all that, say 3 or 4 weeks later, you find that they are able to fall asleep much easier. Because they learn to compartmentalize their life. The daytime is meant for planning, for all this mental activity. Nighttime is meant for rest, for them to sleep. And the other issue I find very, very important is to address the issue of conditioning. A lot of our patients actually have very, very poor sleep hygiene. They will actually, watch television in bed, surf the computer in their bedroom, go onto the internet, and so on and so forth. Because the minute once they start doing all that, their mind will start to associate the bedroom, the bed, with all these activities rather than with sleep. So very often we need to spend time, going through all this sleep hygiene education, getting them to maintain a regular wake time, avoid excessive time in bed, because once they do that, then they will start to use the bed to rest rather than to sleep, and get them to avoid having naps in the daytime unless they are doing shift, and also get them to expose themselves to bright light while awake, and especially early in the morning, because once they are awake and then they get exposure to all this bright sunlight, that will send a very strong signal to the brain that it's daytime, and then they need to be fully awake. So come nighttime, when there's darkness, the brain will produce a hormone called melatonin, and that will enable them to sleep better. So exposure to bright light when they are awake will help to stabilize their circadian rhythm. And we also advise them to use the bed only for sleeping and sex, and not for anything else. Again, that's to get them to the mind to associate the bed with sleep rather than with other activities. Always advise them to avoid nicotine, caffeine, and alcohol. Get them to exercise regularly early in the day, and then do something relaxing before bedtime. Also get them not to watch the clock, especially if they go to bed and they can't fall asleep, they'll start to look at the clock. Then they'll think, oh, 2 o'clock, I'm still awake. 3 o'clock, I'm still awake. 4 o'clock, I'm still awake. And you can imagine, the more they monitor, the higher their level of anxiety. So for those of you who are already asleep, it might be time to to look up and look at this, enjoy this piece of cartoon. Yeah, how we wish we can all do that. Huh? Okay, so certainly in the treatment, we also need to get patient to modify the headache-related kind of behavior, encourage the patient to take part in activities despite the presence of pain. It's kind of we need to get patient to break the vicious cycle. Yeah. And again, very often we need to spend time talking about how they can learn to manage stresses better, be in terms of time management, delegation of work, knowing their limits, and so on. Yeah. And again, for those who are in a supervisory role, or they actually have subordinates under them, so we get them to learn to delegate their work and get them not to over supervise and do not have the attitude that others cannot do the job as well as you can, and get them to know their limits. And if possible, to learn to say no. If they, sometimes they are too obliging and tends to say, find it very hard to decline people's requests. And get them to invest time in building strong family relationships. Get them to spend time with their family. And also developing friendships. Yeah, these are all very, very important issues that we need to explore with the patient to cultivate a strong social network and to plan social activities. And these are some of the common beliefs that we are able to identify in patients who are very, very prone to stress. For instance, some of these patients may have this kind of beliefs. If I make a mistake, something disastrous will happen. If I'm criticized, it means I will suffer humiliation. I must be competent in whatever I do all the time. So you can imagine, if you have this kind of beliefs, which is almost very hard to achieve all the time, it's going to make you more prone to having anxiety, depression, and other kind of stress-related symptoms like headache. And very often you need to explore with patients how they can manage anger better, okay, and not to displace their anger onto their loved ones, but that by itself will generate more problems. And very often they need to have a good sense of humor so they can combat all these stresses in life. And we also spend time talking to patients about the need to involve in physical exercise. Certainly exercise will help to improve the person's sleep and also help them to release their aggression and frustration, then gives a person a better sense of well-being through the release of endorphins. I begin to realize that you all don't have very much of a sense of humor today. Okay, yeah, we also explore other activities that patient can use for relaxation. And very often we also engage patients in some deep breathing techniques. So, very often when you're under stress, under tension, most of us would tend to breathe faster. So that will actually make us even more anxious. So if you try to slow down your breathing, purposely make an effort to actually slowly breathe in and then very, very slowly breathe out. That by itself will actually prevent you from becoming anxious, becoming tense. So we actually spend time, getting patients to practice all these deep breathing techniques. So whatever method that patients decides to use for relaxation, be in terms of exercise, be in terms of learning yoga, so on and so forth, or meditation, yeah, or even hygiene. Yeah, all these methods will take time to work. So very often we need to emphasize to patients that they need to rehearse and practice all those methods and be more patient. And again, the key to everything is patience. Yeah.